You're welcome to this talk. It's Tuesday the 13th of April. Now, I hadn't really planned on doing this talk today, but I was looking at the status of therapeutics for COVID-19 disease last night, and it kind of came together. Now, when we're fighting disease, we want to prevent it, of course. That's vaccination. But when the disease occurs, we want to treat it. That is therapeutics. So we prevent COVID-19 with all the social distancing and non-pharmaceutical interventions that we know about, of course, and the vaccines. But when people get sick, we use, or we would like to use, therapeutics to treat the illness. Now, it's been quite disturbing lately, the way that people are being seen these two as opposing. They're not. We want to prevent and we want to treat. If we want to prevent, that doesn't mean we don't want to treat. If we want to treat, that doesn't mean we don't want to prevent. Of course, we want to do both. So let's kind of keep this together. Anyway, what started me thinking on these lines last night was the World Health Organization latest COVAX news release. So COVAX, as you know, is this idea that we need to vaccinate everyone in the world, which of course we do, working through the World Health Organization. Now, the first international delivery was Ghana on the 24th of February, so it's a fairly new programme. Now delivered vaccines to over 100 economies. Now, that's the way the World Health Organization put it, economies rather than countries. So that's the way they put it. And so far, they've given out 38 million doses of vaccine. AstraZeneca, Pfizer-BioNTech, and vaccines from the Serum Institute of India. And delays in planned deliveries for March and April have been announced. Now, to be quite honest, 38 million, okay, it's a lot of people, but the world population now is well over 7 billion. So this is the most, well, it's a start. You can't really say more than that. It's a tentative start. Long way to go on this yet. Because as of the 13th of April, 797 million doses given in 154 countries so far. So we've given 797 million doses globally. That's doses, not people vaccinated. We're now giving 18 million doses per day. And of course, if we're on a 2-vaccine schedule, that's only covering 9 million people. I know that the Johnson & Johnson vaccine is a single dose. But most are still 2 doses. So for a further 7 billion people needing 2 doses, that's well over 2 years. Now, we really need to get a grip on this, because if we don't start vaccinating a lot of people very quickly, we're going to get more and more spread. We're going to get more pain, suffering and death in many parts of the world. And we're also going to get new mutants, which are potentially more transmissible, potentially more pathogenic, things we've looked at before. So that was what started my thinking about vaccines. And then I went on to the World Health Organization's Solidarity trial, which, as you remember, was looking at treatments, at therapeutics. So this is their site there. I've put the link there. You can read all this straight from the World Health Organization site. It's all there. It's all pretty clear. It's all public domain. So this was the WHO Solidarity trial. Now, I remember back at the start of this pandemic, it's probably about, when would it be? Sort of February, March, April time last year, Mike Ryan on the World Health Organization saying there's about, I can't remember the figure, it was many tens, I think it was about 80 or 90 clinical trials going on in China. And we were thinking, oh, that's good, lots of clinical trials going on, we'll be getting therapeutics soon. But nothing seems to have come out of that large number of trials, unfortunately. So the Solidarity trial was the World Health Organization trying to bring together countries to do this on an international basis. And they've had 12,000 patients in 500 hospital sites in 30 countries. So it's been a reasonably good attempt at coordination. Found that all 4 treatments evaluated, these are direct quotes from their sites. Now, remdesivir is an antiretroviral drug that they evaluated. Hydroxychloroquine was an antimalarial drug. Lopinavir, ritonavir, this is a fixed combination medication used for treating HIV. And of course, HIV is an RNA virus, so it does make sense that this could potentially treat COVID-19 as well. So well worth a try. It makes a lot of sense. And interferon is also a known antiviral. But their conclusion was these had little or no overall effect on mortality. Unfortunately, initiation of ventilation, duration of hospital stay in hospitalised patients. So basically, the Solidarity trial drew a bit of a blank according to their criteria. Now, the dose of hydroxychloroquine used was large, and we'll look at that again in a minute. The Solidarity trial is considering evaluating other treatments to continue the search for effective COVID-19 therapies, they're saying, but I'm not quite sure what they're testing at the moment. So I'm not quite sure about that. I'm not sure they're doing any therapeutic trials at the moment. So far, only corticosteroids have been proven effective against severe and critical COVID-19. We know these are effective. More of these when we look at the recovery trial in a minute. And the WHO has come out firmly against ivermectin. WHO advises that ivermectin only be used to treat COVID-19 within clinical trials. So they've come out pretty clearly against ivermectin. Plenty of references there for you to look at. Not saying I agree or disagree, just reporting what they're saying at the moment. Now, moving on to the UK-based recovery trial, and we can see that one there again. This is all information's all readily available. This is the UK recovery trial, and you can browse that. Lots of interesting information there. Now, we're going to be talking about therapeutics here, the medications that can be used or have been trialled and been trialled, literally used in trials to see if they're effective against COVID-19. But of course, we would never make on this channel any recommendations for anything that you take personally. So this must never be used for you to base your drug taking decisions on. Always go to your own doctor and prescriber. I have to say that. But going back to the recovery trial, azithromycin was tried. Well-known antibiotic, commonly used. Now, of course, antibiotics don't have antiviral properties. They are antibacterial. But this one does seem to. It's kind of an exception. So this one was worth looking at. Azithromycin. Recovery trial finds no benefit from azithromycin in patients hospitalised with COVID-19. So that didn't work. Then they looked at convalescent plasma, which we've looked at, taking plasma with antibodies in from people that had recovered. The Data Monitoring Committee saw no convincing evidence that further recruitment will provide conclusive proof of worthwhile mortality benefit. In other words, this one was stopped before the trial was actually completed, because the data monitoring group that looks at the interim data said this isn't working. And then the jewel in the crown, dexamethasone steroid. We've been using this for as long as I can remember. I certainly remember using dexamethasone 25, 30 years ago, and I'm sure it's been around much longer than that. And here we have it. Dexamethasone reduces deaths by up to a third in hospitalised patients with severe respiratory complications of COVID-19. Now, the thing about COVID-19 is it's a staged illness. Dexamethasone is a steroid. It reduces inflammation. So you wouldn't give it in the first week or so of the illness when the virus was causing the problem. But when these immunological inflammatory reactions are causing the problem, dexamethasone, as we see, reduces deaths by up to 1/3 in hospitalised patients. So staggering success. Hydroxychloroquine. Again, this is the recovery trial. No clinical benefit from the use of hydroxychloroquine in hospitalised patients with COVID-19. But there is a big but about the dose that they used there. It was a very high dose, and there's a question mark over that, but it's never been repeated. Again, the anti-AIDS, antiretroviral combination made sense to look at that because it fights RNA viruses in HIV. Would it fight RNA viruses in COVID-19? No clinical benefit from the use of that combination in hospitalised patients with COVID-19. Tocilizumab. Well, tocilizumab is a recognised drug, and it ends in mab, so it's a monoclonal antibody. It's artificially synthesised antibodies. And it doesn't attack the virus itself. It actually inhibits aspects of the immune system. We have looked at it before. Tocilizumab reduces death when given to hospitalised patients in severe COVID-19, so that's good, and this is being used. Shortens time until patients are successfully discharged from hospital. And, as I badly spaced out on my paper, reduces need for mechanical ventilation. So there we go. From that lot, we've got dexamethasone and tocilizumab, which are used. So that's kind of that story. Now, let's just go onto that screen a minute there. So that was the Solidarity trial, that's the Welcome trial. This is an article about ivermectin from Pharmacy magazine. And of course the links are there. Read it for yourself. So let's report what Pharmacy magazine is saying about ivermectin, which we note has not been part of the recovery trial or part of the whatever that first trial was, the World Health Organization trial, the Solidarity trial. So Pharmacy magazine speaks. This drug was introduced in 1981. It has antiviral and anti-inflammatory properties, they say. This is not me talking, this is from the article. Some 4 billion doses have been taken over the past 40 years, they say. Good safety record with minimal toxic effects, they say. WHO model list of essential medications as 3 milligram tablets, they report. Countries now including ivermectin in their COVID-19 management strategy. They report that it is Greece, Bulgaria, Macedonia, Slovakia, Czech Republic, and there are others. Frontline COVID-19 Critical Care Alliance recommend the use of ivermectin, and they call for the rapid introduction of ivermectin to stem the tide of infections. Interesting. Pharmacy magazine direct quotes. Prophylactic treatment can be given with 2 doses of 0.2 milligrams per kilogram 48 hours apart once a month. So they're saying 2 doses once a month is prophylactic. For early outpatient treatment, a daily dose of 0.2 milligrams per kilogram for a maximum of 5 days is recommended. And again, we have to remember this is not me advising you. This is me presenting educational material for your education. But these are direct quotes from Pharmacy magazine. I am not prescribing drugs to anyone. Interesting. Early outpatient treatment, so catching it early in the disease. A daily dose of 0.2 milligrams a kilogram for a maximum of 5 days is advised, is recommended. That's what they're saying. In the UK, the best way forward will be for the Healthcare Medicines Regulatory Authorities to authorise the MHRA to authorise the use of ivermectin for prophylactic and treatment of COVID-19 on the basis of the published evidence to date, is what the journal article is saying. Next, the drug could be made available through community pharmacies, either using a patient group directive or by making ivermectin a P-medicine. I think that's one a pharmacist can basically advise you to take. Ivermectin would then help to save lives and reduce suffering until the majority of the population can be vaccinated. Fairly to use, a cheap, safe drug that reduces the severity and duration of infection, as well as the risk of death and transmission, seems incomprehensible. So that is from Pharmacy magazine. Now, thankfully, the disease is getting controlled, more controlled in this country, although people are still dying. So therapeutics are still essential, but in poor parts of the world, people are really suffering at the moment. So it really would be good if agencies considered what the Pharmacy magazine is saying and compared that against their current recommendations, which are basically saying ivermectin is not recommended. So that could be a way forward for them to read the article in Pharmacy magazine and take on board what the Pharmacy magazine is saying. If they then want to reject it, fair enough, they reject it. But that is from there. Now, just to give you full information, I put the first video we did with Dr. Tess Laurie onto Facebook. So a few former students and things follow me on Facebook, and it's been labelled as partly false information. Now, I was going to do a bit more on this and give you some information about the report that was written to say why that was false information on Facebook. I don't think I'm going to do that at the moment. To tell you the truth, I'm not quite sure what I'm allowed to say and what I'm not allowed to say from these reports. But I will tell you that the report that was written to say that the information that Dr. Tess Lawrie and me were discussing was wrong was written by, so this is just basically a casual post on Facebook, only probably about 20 people had liked it or something like that. But there was an article there, I don't know, 1,500, 2,000 words long, perfect English, clearly written by, the editor is named on the piece, clearly written by a competent academic author. And basically, I would say, for me to write that article, if you're up to date with the subject, will probably take a day's work. So it just surprised me that an academic took a day out of his time to repute some random video on Facebook. I have written to him to say, will you come on the channel and defend your views, because I disagree with quite a few of them. I'll maybe tell you a couple of things he said, actually. He said this video also misleads viewers by suggesting that safety data regarding a drug's use for one purpose applies to different uses. Well, of course it does. The toxicology of the drug is the toxicology of the drug. That's normally the case. There are exceptions. If someone's got meningitis, you don't want a blood that goes across the blood-brain barrier. But basically, the toxicology of the drug is the toxicology of the drug. I really don't know why he's saying that. He says the safety profile of a drug in one situation doesn't automatically prove that it's safe for patients with a different disease. Now that's true, but the toxicology of the drug is basically the toxicology of the drug. There are there are some exceptions. So what he's saying is not technically wrong, but it's not kind of what we tend to go on as a common issue. He also says this in the video. Lawrie also discussed the affordability of ivermectin and how it can be easily and massively produced. Some have argued that the reason ivermectin isn't being deployed against COVID-19 is that it's cheap and wouldn't generate as much profit for pharmaceutical companies. Simultaneously, we can conclude that a cheap drug thus widely available would be administered to tens to hundreds of millions worldwide would be a hugely lucrative business. But as we've said, the cost of ivermectin, I think she said it was about $168 a kilo, and that would presumably treat thousands of people. So to say that for this critiquer to say that there is big money in ivermectin, I think is misleading. So there you go. The debate goes on, and I'm not making recommendations. I'm not making conclusions, but I'm just trying to reflect openly my thought processes from the information that is currently available. But I must say I was pretty surprised to find this, and that someone had gone to so much trouble to repute our discussion. Watch it for yourself, decide for yourself. I found Dr. Lawrie to be a first-class academic, I must say. Okay, that is us for today. Nothing else to say, really, apart from thank you for watching.